Cervical Instability by Sarah Hartford and Megan Ostrom.
Cervical instability is defined as the loss of ability of the cervical spine under physiological loads to maintain a relationship between vertebrae. This may result in the spinal cord or nerve roots becoming damaged or irritated. Patients may present with deformity or pain.
The cervical spine is a vulnerable structure due to the fact that its primary function is for mobility, not stability. Cervical instability has the potential to affect 70% of people within their lifetime.
For diagnosing cervical spine instability, there is currently no gold standard. Medically, X-ray or MRI may be used. With an X-ray image, the doctors will commonly look at the Atlano-Dens interval, or ADI. Cervical instability can be diagnosed if in adults the ADI is greater than 3 millimeters, or if in children it's greater than 5 millimeters.
Cervical instability is most often a result of a traumatic event, but it can also be caused by other pathologies. We will discuss one of these later in the presentation. Some signs and symptoms of cervical instability can include neck pain, clunking, headaches, altered range of motion, intolerance to prolonged static postures, fatigue and inability to hold head up, and if severe, can cause radicular pain.
If cervical instability is suspected, the physical therapist will perform a physical exam. In this exam, the special tests that may be used include the sharp purser test, the transverse ligament test, and the alar ligament stability test. We will go into more detail on these tests over the next few slides. Another test that may be performed is the distraction test. This will be performed if the patient complains of radicular symptoms. Some other findings from the physical exam may include poor coordination and neuromuscular control, abnormal joint play, range of motion that is not fluid, and possibly movement through a fulcrum.
The transverse ligament test looks at the disruption of the transverse ligament. A positive test are myelopathic symptoms. If this test is positive, the physical therapist should perform the sharp purser test.
The sharp purser test looks at the disruption of the transverse ligament. A positive test would include a clunk, a loss of headache, or a decrease in numbness reported by the patient.
The alar ligament stability test determines the disruption of the alar ligament. A positive test is delayed movement, dysfunctional movement, or no movement at the C2 spinous process.
There are many interventions for cervical instability. The following are a few examples. For conservative treatment, there is postural education, which may include chin tucks or scapular retract. There's also neuromuscular reeducation using biofeedback pressure cuff, taping, or gentle range of motion. Neck strengthening may also be used with the pressure feedback cuff and also increasing flexor endurance of the neck muscles. Headaches may be relieved through OA release or distraction. When conservative treatment fails, patients may have surgery. This is often for patients with severe neurological involvement.
Now we are going to discuss the prognosis of cervical instability. Strengthening, stabilization, posture education, and neuromuscular re-education have a positive effect on this population. Prognosis depends if the instability is in conjunction with another medical condition. Cervical instability may indicate early degeneration of the intervertebral discs in the cervical vertebrae. Fusions should be set aside for those who have not benefited from conservative treatment.
Outcome measures for the cervical spine may include Patient-Specific Functional Scale, PSFS, or the Neck Disability Index. The PSFS is when the patient identifies 3 activities they have difficulty with. Each activity is scored on a scale of 1 to 10. The higher the score means the higher their functional level is. For the Neck Disability Index, they report on 10 items. Each item is scored 0 through 5, and on this one, the higher score indicates greater disability.
According to one study by Pichel et al., children in this population have a higher ADI and larger spinal canal widths. According to another study by Kramers et al. Titled Risk of Sport Activities in Children with Down Syndrome, Atlantoaxial Instability, 10 to 40% of children with Down syndrome have atlantoaxial instability. The aim of this research was to determine if these children run the risk of spinal cord compression when they play sports. The children in one group were allowed to play their specific sport or exercise, when the children in the other group were told not to play risky sports and to not make risky moves during any other physical activity. After 1 year, there was no difference between the groups on scores in a functional motor scale, frequency of neurological signs, or changes in the atlantoaxial distance. The result of this study was that there is no reason for these children to stop playing certain sports, and there is no need to be screened by a radiograph before they start playing their sport.
Thank you for listening.